Great. Well, I appreciate everybody here. Michaela and I have a couple of projects to talk to you about. As Carly indicated, lessons learned from the deployment of new clinical alarm solutions. So we'll get into that without any further ado. I will just do a quick introduction on myself, and then I'll turn it to Michaela to do the same. So again, Izabella Gieras, Director of Clinical Engineering at Cedars Sinai Medical Center, but I also have Huntington Health, formerly known Huntington Hospital, both in the LA area, Huntington in the Pasadena area, for those of you that are more local to that area, and then Cedars Sinai Medical Center in the Beverly Hills area. Previously, I won't go one by one, but just wanted to let you know a little bit of my history. Oh gosh, 22 plus years now within clinical engineering. Previously, 2010 is when I came to Huntington Hospital. I was with Aramark stationed at Mount Sinai Medical Center in New York City for a couple of years. Prior to that, Beaumont Hospital in the Detroit, Michigan area, which from what I'm hearing now, so many years later, has expanded into many, many multi-hospital systems. Very much involved in ACCE, AME, for those of you that know me through those past experiences. So just putting a pitch for getting involved in all those other organizations as well, and then a few other things. Without, again, further ado, I'll turn it over to Michele.
Thank you.
To do his introduction.
Yes, good morning, everyone. Thank you for joining us. My name is Michaela Manzoli. I am currently, and actually only for the next 10 days, Senior Clinical Systems Engineer at Cedars Sinai. Today marks the start of the countdown because on October 24th, I will start my new role still at Cedars as the new manager of clinical engineering under Izabella. So I'm very excited for that. But for now, now here I will be, talking about my current role in the device integration team, and I will talk about my team a little later. But I am originally from Italy, as you might guess from my accent. I was born and raised in the region between Florence and Venice. If you watched or are planning to watch the recent show with Stanley Tucci, I believe it's called Searching for Italy. That's episode 3, titled Bologna. So just in case you're interested. But I've been part of the American HCM community for the last 8 years. Before moving to the US, I worked with the Italian Ministry of Health in the medical device regulatory affairs field. And also I worked with the largest clinical engineering ISO in the UK. Like Izabella, I attended the well-known internship-based master's program at UConn. I interned at Yale Hospital. And before that, I attended the only university in Italy that offers masters in clinical engineering. Actually, this year marks the 30th anniversary that the University of Trieste, has been educating clinical engineers in Italy that are now heading clinical engineering departments, both nationally and, of course, internationally in Europe and in the US. Certified clinical engineer, and I've recently started serving on the board of ACCE as their secretary.
Thanks, Michaela. And Michaela has not mentioned, but recently, within the last few months, has gone to Italy to speak on behalf of their Italian association about clinical engineering. I think it was like the State of the Union, what clinical engineering is in the United States, and so on. So it was quite a privilege because I was just letting him know that at that time that, gosh, many, many months ago, I was doing something very similar. When that was my first time to go to Rome and be able to, again, speak about clinical engineering at that time, invited by the Association of Clinical Engineers in Italy. So international, national speakers. So we are very excited to have Michaela join the clinical engineering department at Cedars Sinai. So thank you, Michaela.
And we are hiring BMET and CEs. So
yes, making it for everything at the same time.
Yeah.
So, let us go ahead and start the presentation. I'm assuming all of you are interested in some way or another on clinical alarms related type of topics. Hopefully what we present to you will be of interest. These are short presentations, so hopefully we'll have some dialogue towards the end, and obviously throughout the conference we're here and available. So again, briefly around what we're going to talk about today. Session summary objectives. We'll talk a little bit about national regulatory standards, very brief one slide, and then really get down to the case studies of what we completed within the last couple of years on the Huntington side. And then Michele will talk about an alarm-related project on the Cedars Sinai side. And then, of course, we'll have some lessons learned to share with you as well. Okay, so again, very much what we've already talked about. We're going to talk about both hospitals and how both hospitals have implemented, amongst other, obviously, alarm-related strategies, a couple that we will share with you today, and also talk about the process, what was involved, how we went about accomplishing the different projects, not just within the planning, the go live, but of course, what's also very important is the sustainability after the go live. And as I mentioned earlier, Joint Commission and some of the other regulatory bodies, keeping that in mind for all the projects that we do. And I'll actually be asking you guys some questions because I'm interested as we actually transition. These are just session objectives, which we can probably skip for the sake of time, because I want to make sure that we also have some dialogue. But how many of you have established, as a result of the Joint Commission, patient safety goal, clinical alarm committees or work groups, and are still actively involved in those committees?
No, actually, we just started it back up.
Oh, okay. Yep. I know COVID, we've actually put some pause on those activities. So is that because of COVID and some other priorities, obviously?
Yeah, so we started it back up. This was quite a while ago when they brought out that safety goal. We went through the whole thing, but there's been a lot of turnover over the years. So people were looking at it. And since I didn't turn over, and one of the old guys that's still around move up first time, so they invited me in. So.
Got it. Good, good. So are you doing anything specific, any highlights in terms of initiatives at this time?
Not this time, we're just barely getting started.
Okay, so restarting again. Great. Well, at least it's happening, which is obviously a step forward. Anybody else? Good. I mean, it's hopefully this will energize some of that discussion, so you can take back and perhaps work with some of the clinical counterparts to restart, or hopefully be added to those initiatives if those initiatives are ongoing. So moving on, let's talk a little bit about Huntington. So as I indicated, I represent Cedars, Sinai Clinical Engineering, but also Huntington Health. And I apologize for my voice. I promise I wasn't partying all night, but it's going a little bit away. And then Huntington Hospital, or formerly known Huntington Hospital, now Huntington Health, affiliated last year. That was August of 2021. It took a little bit of work, and of course, COVID didn't really help in accomplishing the end goal for the affiliation, but finally happened. And what that prompted an opportunity for me to be part of the clinical engineering at both, again, the medical center and Huntington Health in terms of the management oversight. It's been, just a little bit now, over a year, because it was October 1 when I started coming to Cedars Sinai. And still, still enjoy those 1.5 hour drive that I do from Altadena, if any of you are from the area. But enjoy it and learn how to be productive during that 1.5 hours in terms of doing business calls and things like that. I'm sure all of you that do that already know. I never had to do that. My commute was 10 minutes prior to that. So I'll certainly learn how to maximize my time. But again, that opened obviously some opportunities for the two hospitals now to be under the Cedars Sinai Health System and join other hospitals, which gives us obviously a lot of leverage when it comes to things, such as service contracts, capital procurements, and so on, which I know is not a specific topic for this discussion, but certainly is something that we would love to talk, hopefully, in future presentations. So a little bit about Huntington Health. I won't go line by line. I know these presentations, there will be recordings and will be available for you to look through the slides. But Huntington, again, Health located in Pasadena. It's about 619. That kind of goes up and down in terms of our licensed beds. But more specifically in terms of the staffing, which actually just recently we hired a biomed on the Huntington side. So it's 8 biomeds. We have 3 support staff. That includes a supervisor now. I needed a backfill plan since I toggle between the 2 hospitals. So we do have an individual that's supporting that, as well as a clinical engineer and administrative assistant, and then of course me in this position. We do now, since the affiliation, report to the what we call EIS, the Enterprise Information Services, which is under Cedars. And actually, my being still a Huntington employee, I report to a Cedars leadership as part of the affiliation. Then a little bit about the clinical engineering department on the Cedars side. I always say 3 times more than what I had or have at Huntington in terms of, again, the number of beds, the number of employees, and specifically looking at the composition of our department, the number of devices, just a little bit over 33,000 and counting. Now with Michele's help, hopefully we'll be able to continue to work on refining the inventory as well as the recruiting, which he has mentioned. We do have some open positions for both BMed and a clinical engineer. And like I said earlier, this department also reports to EIS. Okay. So a little bit about the project on the Huntington side. Again, very high level, and I want to make sure that we have enough time for Michele's exciting alarm solutions project. So what I wanted to talk about over the next few minutes is a project that we have implemented at Huntington just over, gosh, 1.5 to 2 years ago now. And it's our middleware that we use for alarm notification that integrates between our patient physiological monitoring and end user communication devices. We do have, I guess, for full disclosure, although we try not to obviously be specific on the vendors, but we do have a Philips system. We have had in the past also a Philips emergent middleware, and decided after looking through the market to stay with Philips, their new event care assist application. How many of you, with the raise of your hands, have some type of a middleware application today? Okay. Good. Is that working good for you? Are you involved in managing it today within clinical engineering? Yes? No? IT? But I'm assuming still some sort of partnership, right? If something goes wrong, it's not like this, right? They all work together, hopefully. Good, good, good. Perfect. So for us, it was really, again, as I indicated here, end of support technology. We were racing against time, and again, unfortunately, it happened during COVID, so a lot of delays, but the vendor was actually obviously very, very reasonable in understanding, as many have actually been during the pandemic. The other big stuff that prompted us to really look at an upgrade, other than, of course, end of support, which really is always the main, one of the main factors, is insufficient analytics. We really wanted to take a deeper dive into our ability to look through the reporting that's also mentioned there, work with our clinical staff to be able to, oh, our alarm didn't go through, or what kind of alarm, be able to take a deeper dive and actually look at the logs, be able to easily interpret the logs and provide some meaningful information back to the end users. On the Huntington side, the end users very much relied and continue to rely on clinical engineering to be able to provide that investigative work and assessment of logs, even though all the supervisors and managers were given access as well and could certainly do that from the clinical standpoint of view. They're always tell us, well, we're too busy. Well, who isn't, right? But at the same time, it made us the primary, I guess, investigators and assessors of those logs, which helped us increase our knowledge of the system overall. And like I said, the interpretation, the QA/QC data was not very user-friendly with the old system. It was very archaic, and a lot of those logs were lengthy and had to be reformatted. So again, not very user-friendly in terms of clinical engineering being able to respond quickly and provide a complete assessment of an event or some type of an inquiry from the clinical staff. So the journey, of course, we embarked on the journey, and like I said, it was during the COVID times, but certainly delayed things, but did not prevent us to accomplish our goals. Be the champion. So I know some of you have mentioned that you are the champion or the owner of the middleware system. Some have not, but obviously you still play a critical role, especially if you have a system today, maybe looking at an upgrading or some enhancement. Certainly make sure that you have a seat at the table. Project management strategies. For us, it was kind of like I said, during the pandemic times, a lot of things were going on. So we actually, not that everybody has to do it the same way, but we tapped into our project management office, PMO. I don't know how many of you have those resources available. If you have it and it's available to you, use it. Because even if they just schedule meetings, do meeting minutes and keep you on track. Did you deliver this? Please do this. Did you contact the vendor? They kind of keep you going, and you can focus on all the more of the subject matter expertise that you bring to the table. Appropriate technology selection, as I mentioned a few minutes ago, we stayed with the same vendor. We're also somewhat in a time crunch, a lot of things going on, as I mentioned, but still had the time to validate that even though we're upgrading with the same vendor, the technology still meets our needs based on the different things that I mentioned in the previous slide. This is something that we normally don't do, but we did in this case, something to consider, and maybe you already do it, but it worked really good for us. We split the project into 2 phases. So we did 2 out of the 7 telemetry units, which are the primary units that use the alarm notification strategy today. We do have 1 PEDS hardwired unit that is doing that as well, but that was added towards the end of the project. So what that gave us almost a pilot, which we again worked with the vendor to give us a really good deal to do that pilot, validate, and buy us time to kind of work out all the kinks and make sure that everything will flow smoothly when we do the remaining 5 units. Because on the Huntington side, there are about 220, well, actually 221, used to be 222, 221 telemetry beds. So that's the scope of the project. And we have 18 PEDS beds, like I said, that were added. They're hardwired, but use the middleware technology. So of course, things like team approach, voice of the customer, utilizing the clinical alarms management committee that I mentioned, very essential. We had all that documented and make sure that we have it in the committee repository as we started looking at the strategies, looking at the project scope, and of course, making sure that the members of the committee, as well as the overall telemetry unit representatives, are involved in the project. And like I said,
committees set up ahead of time?
Yeah.
Or, I mean, it was an existing committee and you just used it?
Yes, correct, yes. So as I asked that question earlier, in terms of that joint commission goal back from 2012, 2013, and so on, I know many of us, including Huntington, and I know Cedars as well, established a committee. So that committee has been long in existence. It did get paused during COVID, but again, we've used them and the members that we have on that committee to help us refine, the strategy, the alarm escalation, and all the other, obviously, solutions that we needed to put in place. And then, of course, support from the vendor, essential. So a few things in terms of user requirements. I know you'll have those slides too, but obviously the main thing for us was the integration with the patient monitoring system, because I know there are other, I don't want to call it a third party, but other type of solutions for middleware. We obviously stayed with the same vendor as what we have for our patient monitoring system. So that helped make sure that we have that validation in place ahead of time, as well as the FDA approval, because these systems, I'm yet to see any type of FDA approval of any of these middleware systems as a primary notification. They're FDA 510K approved by secondary. Your primary is always the person that's sitting in front of that monitor, whether it's decentralized or centralized, which, that could be a separate discussion on how that's done across different hospitals. And on the Huntington side, we actually ended up with this system in terms of the notification to the end user device, but also established during that time what we call TMS, telemetry monitoring services. On the Cedars side, we have something similar. It's called
CMC,
CMC,
Centralized Monitoring Center.
Monitoring Center, right? Center. Sorry, learning all the acronyms. High reliability, robust design and support. You know, obviously this is a critical system that delivers alarms. You want to make sure that you have a high reliability system that's been validated, tested. You know, moving forward, obviously you have regular, you know, patching of the system or the application and so on. Obviously the delivery of that to the smartphone, as I mentioned, you know, other than having some type of a decentralized or centralized monitoring solution, in this case, we also wanted to make sure that it integrates and it's validated with the smartphones, which were the iPhone 8s at that time, that these alarms were going to. Obviously, prioritization, escalation of alarms, that's where that clinical alarms committee came in. We talked about the seamless communication. And then this piece here, gain insight into alarms with data and caregiver reports. So again, even though our caregivers, the supervisors and managers have access to those reports and the data, they can pull it up on any given day. They still defer to clinical engineering to be able to do that assessment or look up those reports. So we wanted to make sure, and we spent quite a bit of time during the planning phase to make sure that, again, it's a much improved solution for us compared to what we had before. Availing data, and like I said, to decision-making, educational initiatives, root cause analysis, especially if you actually have an event and something happened, the alarm didn't deliver or missed alarm, and what we normally get, oh, I didn't get that alarm. So, okay. So that prompts an investigation, and we have to go through the, you know, the reports, the data, which again, it's much more user-friendly at this point. So some of the user interfaces, how many of you use, or those that have said they have middleware, use iPhones as their end user communication device? What do you guys use?
Just got there.
Oh, I can do that. Which, by the way, Roberto, not to put him on the spot, he was the associate director at Cedars Sinai up to what was that, end of July, August, right? When you moved over to Stanford Children's Hospital. So he's not necessarily with us, but we'll be familiar with the Cedars Sinai case study. Yes.
If you look at integrating other alarms besides just patient monitoring, you know, nurse call system and that kind of stuff.
Yes, and we'll talk a little bit more about another example on the Cedars side from a ventilator perspective. But yes, on the Huntington side, when we did the planning phase, we kind of looked ahead. We have not operationalized that by no means yet. But yes, we looked at ventilators, not necessarily nurse call at this point. Nurse call is under facilities. This is under clinical engineering. So not that it's a battle, but you know, I don't own it. So it's, you know, we're just not moving fast enough in that direction on the Huntington side. Beds and other things obviously is a potential for integration. But what we did look at is from a ventilator perspective. We have noticed that that is something that today is more of a localized alarming, and we definitely need to make sure that as part of our pathway for future integrations from alarm management standpoint of view, ventilators were going to be our next
So
technology.
I got one question.
Yeah.
So do you have different sets of alarms getting on your codes? If your code is in an ICU, the code card might not be there, but if it's in a general care movement that has to be announced over the PA, do you have different sets of rules then that you set to do that?
Yeah, for the coding, yes. This does not have anything to do with that. This is strictly the alarm notification from the telemetry. So actually, as I mentioned, the 221 telemetry beds that we have, the alarms that we have selected, and I do have a slide and maybe more of an eye test, but for the red, if you're familiar with the Philips system, which I know it's very similar on other modalities or other vendors as well, but the red, yellow, and the blues, and we have selected a subset of those alarms through the clinical alarms committee that we talked about that helped us decide which of those alarms will now be going to the iPhone. So yes, so we've done that due diligence, but from a code perspective, we have a different escalation for that. And like I said, I will have a slide on the escalation that we also have for this particular technology in terms of what happens if you have a red alarm. It goes to the nurse, the PFC, which is our patient flow coordinator. And then if that doesn't get responded within a certain time, it then escalates to everybody. It's different for yellows and of course different for the blue level alarms. So as I mentioned, iPhones we've had here, obviously We used to have the old Zebra phones. I don't know if anybody is familiar with that on the emergent side. Very archaic, so it was definitely time to move away from that. So there was quite a bit of validation, which actually some of that happened at the same time. But again, introducing an iPhone, Apple platform, everybody was familiar with it, still is. So it was easy to add the app along with actually Volt, like the V there, which subsequently we've got through some recent upgrades on that. So these are some older pictures, but again, familiar platform, easy to use, and iPhone being, expandable, flexible platform in case we need it in the future, and probably will add additional applications. So again, this is a snapshot to show you, the red alarm here, what that looks like with a snapshot, a few second snapshot of the waveform. We are hoping in the future to add a real-time waveform that you can actually, be able to troubleshoot, diagnose, not necessarily diagnose clinically, but be able to look at it before you actually go into the patient's room. Just because you have that waveform doesn't mean that you shouldn't go and respond to the patient, especially if it is a red alarm. But it, again, kind of gives you that preview as you walk over to the patient's room. And similar for the yellow alarms, ability to acknowledge those alerts, obviously alerts on the phone, and also there's ability for us to look at the historical alarms, unless obviously the nurse chooses to remove those, which they can. Those do not have to stay there permanently, but can be retrieved again from the server as needed. Again, this was that I test chart that I mentioned, and any of you that are interested to talk more about it or would like to get some more information on how we did our escalation, I'll be happy to talk about offline. Again, this was done in collaboration with our clinical staff from those impacted units, as well as the clinical alarms committee, on what we decided, which this slide doesn't necessarily have it, but which reds, which yellows. It has a little bit of that actually here, which reds and yellows we have decided to send over to the iPhone, and like I said, our escalation in terms of who gets them at what point of time if the primary nurse assigned to the patient does not respond. So again, this is maybe an eye chart as well, but it tells you, it gives you a little bit of a snapshot of the different type of reports that we are able to get from the application today. You can customize it, which is not shown here in terms of timeframes, units. You can even drill down to the actual, patients, the type of alarms. You can look at the specific one, if there's a specific one in question, or you can, again, for the QC/QA type of or educational reports, you can, go over a certain period of time and use that as a training tool as needed. So some lessons learned, a lot of things that we've already talked about. Like I said, for us, having a project management from PMO worked really well, kept us on track and made sure that we, are delivering and following up on everything that's needed. Collaborate. That's kind of a given. Where feasible, implement that phased-in approach that I mentioned. It helped us kind of work out all the bugs, make sure that we have good planning for the subsequent phase, which was much bigger than the first one. First budget, without saying, has to be secured early unless you have some other creative ways with the vendor to be able to work through that. And of course, the downtime planning, because there is going to be downtime with many of these, obviously. Implementations, we've always been told nursing plans many months in advance. So don't come to me a week before to tell me that you need extra nurses or you're going to be down for 2 or 3 hours. Do that 3 months ahead. So make sure that that's done appropriately. And then a few other things, obviously, as always, have an alternative or backup plan in case something doesn't work out with your primary strategy. Kind of a given post-implementation, we still continue to monitor things. We do regular patching, regular QAs. We look at the reports on a regular basis. And of course, reporting the updates. We talked about the alarms committee. EOC is actually our environment of care, is where we report on a quarterly basis. From the alarms committee up to EOC, patient safety, there's a nursing council as needed, where we provide reports on this. And with this, I will turn it over to Michele, and then hopefully we'll have some time for questions.
All right, thank you. Let's see. So before we talk about the initiative at Cedars Sinai, I just wanted to provide a brief overview of our team, the device integration team. So working very closely and very well with the clinical engineering team at Cedars Sinai and with the clinical technology team at Huntington Health, the device integration team operates at the health system level, covering multiple hospitals. Along with 6 other clinical systems engineers, we support not only the classic biomedical device integration functionalities for thousands of devices, but we also support many other systems such as the nurse call system and its integrations, alarm integration and management, clinical communication platform. More recently, we implemented a real-time location system. We're tracking more than 12,000 assets today. Environmental monitoring is also something we are responsible for. And in the last 12 months, we also took over infant protection system and staff duress, leveraging the same infrastructure that was in place, for nurse call automation and real-time location system. We are also we have also implemented an electronic cardiac rhythm strips that saves so much time and paper and money for the hospital, being able to get the snippets, waveforms directly from the patient monitoring system into our EMR. So again, working very closely with clinical engineering from an operational perspective is one of the key for the success of our numerous implementations. So the initiative I'm going to talk about has to do with secondary alarm notification for Bipap and critical care ventilators. It turned out to be quite topical because of a recent recall where the well-known manufacturer suggested connecting their Bipap machine to a nurse call or to another remote alarm system as a mitigation action because of the issues that it was having. For us, we decided to do that before the recall. For us, the drive to implement such an integration was just for the staff to be able to hear alarm from isolation rooms or in general, from a room with a closed door. Now I'm curious, is anybody doing some kind of integration for ventilator alarms today? What are you leveraging the nurse call as well?
Yes.
Yes.
We're doing a couple of things. Yeah, well, we're doing it for that recall, of course. So we're doing the nurse call, and we're doing it in another way. We're actually on our ventilators in one unit because it's hard to see. We got it tied to 2 systems to do alarm one way, but also keep track of it another way. So it's a little confusing.
Yeah, so this is the problem statement. The first step was to identify the integration path. So looking at the different areas, starting with the ICUs, the 2 options were the bedside monitor or a middleware device that many of you may recognize. It's a capsule neuron that we have installed at the bedside for all our ICU beds. In step-down units, we could choose once again the bedside monitor or the 2-jack station that our nurse call system provided. That station was not available in ICU, but is available in step-down units and in med-surg units, where it is actually the only possible option. So, so we actually had to, standardize on 2 different approaches depending on the location. And nursing agreed to that because they understood the different configuration, the different settings, and they wanted us to leverage existing technologies rather than introducing yet another system to accomplish this. So we decided to standardize with nurse call system integration for MedSurg and step-down units, and go with the middleware integration for our ICU rooms. So let's start with the first scenario, nurse call system integration. From a hardware perspective, it was quite easy because it was just about acquiring the exact same audio cables that were already in use for our chair alarm devices, and that that were already leveraging this station that we call 2-jack station, which again was used already for the chair alert and for generically for a med device, which could be a bedside monitor, for example, or an infusion pump. So in many units, these 2-jack stations were already labeled and being used for chair alert or med device, a generic term. So we decided to keep or even the labeling as is at the beginning, and just start. We acquired the cables and secured the cables to all our Bipap machines, so that each Bipap machine now has an audio cable secured to it, so that when used in a med-surg or step-down room, the respiratory therapist would connect the cable into the outlet labeled med device, and they would make a functional, perform a functional test to make sure that the circuit, is uninterrupted, is functional. And then every time the Bipap would trigger a high priority or red alarm, a number of events would happen. First of all, the nurse console, or the white phone depicted here, would ring, displaying the room number and the med device, as you can see in the picture. Secondly, we implemented distributed notification to the primary RN's phone, as well as to the respiratory therapist's phone, thanks to our middleware system, which we will talk more about later. So that's a second notification. And then thirdly, you would have a visual notification. Of course, the call light would start flashing. So centralized at the nurse station with the white phone, distributed, at the caregiver's phone, and then the light by the door. The light would keep flashing until the alert is canceled at the bedside, so the source. Of course, if the alert is canceled at the nurse call system, but it is not addressed at the actual source, so the Bipap would not generate once again an alert. So the understanding that whenever the caregiver cancels the call at the nurse call system, the understanding is that they need actually to take care of to understand what is going on and resolve the alarm condition. Thanks to our middleware system, we were also able to implement an escalation system. So, so that if the alarm condition is not resolved in 60 seconds, we set a rule so that the charge nurse would receive a notification. And that would, increase the likelihood that the alarm condition is addressed and resolved in a timely manner. The second scenario, as we talked about, applies to ICU rooms. And I should mention that while we were able to implement the nurse call integration system last year, we are still in a preliminary testing phase for this more complex implementation. So it consists in leveraging the existing connection that is already in place for Vitals integration. We've been integrating Vitals in our ICU for maybe almost 10 years using these kind of devices. So leveraging the same connection, we would transmit the alarms from the middleware device to our alarm middleware platform, which, if you're curious, is Connexol. Is anybody else using Connexol out of curiosity? So I stand for children. And then again, thanks to the alarm middleware platform, we would be able to again recreate a centralized and a distributed form of notification. In this case, the centralized would be a scroll board that we plan to install by the nurse station, and the distributed would mimic what we've done with the nurse call. So it would be the personal phone for the RNs and the respiratory therapists. Working with, but actually shadowing respiratory therapists, we wanted to actually focus on actionable alarms. So we heard their expertise and their learning from their workflows. We selected a very limited number of alarm types, and we are planning to introduce also delays to allow certain alarm conditions to self-resolve before they're being dispatched to the scroll board or to the phone. Of course, in case of a patient disconnect, we would never introduce a delay, clearly, but maybe for a high peak pressure, a delay of 15 seconds may reduce the number of false alarm and reduce alarm fatigue. And of course, all these decisions are made together with nursing and respiratory therapy leadership. Speaking with nursing leadership, they pointed out that they would rather have centralized alarming prioritized, meaning they would like to see and hear these alarms first by the nurse station, and so leveraging the scroll board rather than sending it to the phone immediately. Also because of the geography of the how the ICU is configured, which is very different from how our med-surg or step-down units are located. All the rooms are around the nurse station, so it worked best for them to not to have to deal with the phone while they're caring for patients, but being able to look at the scroll board. The scroll board would indicate the room number, the alarm type, which is something that we are not able to do that, of course, with the nurse call system, because that's just an electric signal that only indicates it's a high priority red alarm, but we don't know which one it is. In this case, leveraging the middleware system and the HL7 messages, we're able to pinpoint, it's PPIC high for room 7S32. The scroll board, we can customize it with a dedicated sound. It also has lights, so whatever works for them. We plan to pilot this on one of our 6 ICU floors, 24 beds, and iron out any issues, and then implement to the rest of the ICU floors.
Just for verification, that scroll board you're talking about, is that a picture that says 7S32?
Yeah, it's a PoE device. It only requires connection to the network. It is powered through the network. So now we are working with HCI to sort out the facilities work to run this cable so that these scroll boards can be installed by the nurse station. But we have started working with Capsule and Connexol to establish a new alarm pipeline and set up some basic rules that would allow would filter only certain types of alarms, and would also introduce the escalation So in the very unlikely, event that these alarms are not addressed in 2 minutes, and this is another decision by nursing leadership, at that point, both the charge nurse and the primary nurse would receive a notification on their phone. But that is a very unlikely case. But of course, again, they always want to have, a redundant system. So like before, you have the nurse call system and the phone. Now you have the scroll board and the phone once again, so that if one fails, you might have the other. Even if in this case they both the single point of failure would be the alarm middleware. So if the alarm middleware is down, you won't get and you won't get the info from neither the scroll board nor the phone, of course. But if the phone, clinical communication platform is down, which happens sometimes, at least you still have the scroll boards. And these scroll boards, we've had them in other locations. They're quite, robust and reliable.
So on a floor of 24 ICU beds, how many scroll boards?
4. Yeah. So we have 2 nurse stations. So the 24 beds are in 2 wings, and so there are 2 nurse stations, and so we put 2 scroll boards at the 2 opposite corners of
You say there's lights, because it's not tied into the nurse call system. Is the lights
the lights are part of the scroll board, not lights outside of the room.
I'm having trouble figuring out what a scroll board looks like. I mean, when you had the first word scroll board, I thought it's more like our patient. We have a big monitor up there and it's got a lot of data on it. You're just adding this in and maybe.
So in this case, it's just a display with something that scrolls with the. Yeah. So scroll board. Yeah.
Old school scroll
Yeah. Yeah. So it would scroll and show the room type, the room number, and the alarm type.
That's why because to me it's almost like a sticker on the wall.
Yeah. This is not a real picture. I mean, it's a composition, a Photoshop.
How do you go about installing that? Is it you just cut out, or how do you install the scroll board up to that?
It's something that our facilities or engineering team, it requires a few screws, and it's not very heavy. It's lighter than it seems, and it's not very thick. It doesn't require any particular backing, luckily, but it requires network connection, and so that's why it's being delayed. But yeah, the mounting is not what it's delaying us.
I'm still trying to get used to the new name.
Yeah.
For me too, yes.
So to reduce alarm fatigue, we looked at the Johns Hopkins experience with critical care ventilators, where they actually found that the vent alarm conditions resolved within 15 seconds 60% of the time. And so that was a good reinforcement of what we actually experience on the patient monitoring side, where we have been integrating alarm for many years. So we were able to go back and look at our own experience at Cedars, where we have implemented, again, a 15-second delay, which 15 seems to be the magic number for this implementation. And we were able to see really drastic reduction in number of alerts that were being dispatched to the caregiver's phone without impacting patient safety. You can see for the DSAT alarm, for example, you were able to cut in half. For TACI, even, can't even more than that. So we felt more comfortable looking at also Johns Hopkins did something similar and found a way to reduce alarm fatigue, because in a way we are adding more alarms to these caregivers, even if for a good cause it's still more alarms. So we definitely want to avoid alarm fatigue. Lessons learned in general, we're not technical, they're more on the human factor side. Before of an initial inconsistency in the workflow, sometimes the respiratory therapist would not plug in the cable, or they would not follow the workflow on their phone to assign themselves to the room, because if you don't assign yourself to the room, you won't receive any notification. And this is required both for the nurses and for the respiratory therapists. So because of an initial inconsistency, the RT leadership realized they could improve their education process, including some demos on the unit, not just handing out tip sheets, and frequently following up on the unit. So that's what they noticed this was going on, so they started doing some more demos and follow-ups. On our side, we realized that, remember that we decided initially to keep the med device label as is. Well, it turned out that was could be not very clear for some of the, especially the travelers or temporary staff that would not not seeing a specific label, that creates confusion. And so we reevaluated the use of the 2-jack station, the nurse call 2-jack station, and made the decision of actually labeling it Bipap. And so dedicating one of the 2 ports to Bipaps, and that's it. So we did that physical relabeling, but we also mirrored it in the software, so that on the nurse call nurse station, the white phone, they would again read Bipap, and also on the phone, the label would be the same, would be consistent. The importance of setting clear expectations from the beginning. This again, asking the RT, the clinical teams, what they could have done better, especially about what are the expectations and responsibilities of nursing rather than respiratory therapy. So from a workflow perspective, defining as much as possible the different roles, from the beginning to the addressing, how to address an alarm, and what to do if something goes wrong. So, and also they realize that they should reinforce more with the staff the safety aspect of this initiative, because sometimes frontline staff just felt overwhelmed, and they felt that yet other tasks were being added to their already heavy workload. So they just need to appreciate the added safety aspect of what we are doing, and preventing serious adverse events. Thanks to our middleware platform, we are able to monitor monthly activations on the nurse call side, so that we are able to make sure that compliance stays high, and that helps with post-implementation monitoring, something that Izabella also mentioned before. Without that, it's you can have your project slowly being forgotten or fail. So it's really important to keep making sure that the system is utilized and address any issues that may arise. I guess the alarm clock sounded over there. Is it time? Yes, 10:30. Oh.
Yeah,
Any questions? Yeah.
But I know we have a half-an-hour break. So thank you, Michele. We'll open up to any questions or anything that you would like to share based on your strategy.
I have a question. I apologize, let's cover this because I was a little late. But so with this, again, it's strictly just a phone app, correct?
So well, it depends on which one. So in our case with the Vents, we are using our clinical communication platform, which is Volt. I don't know if you've, so Volt receives the alarm notification from our middleware platform, and yeah, and so the notification is within that application.
Okay.
It's not yet another. In Huntington, in the Huntington case, it's a dedicated application.
Yeah, it's an app. I mean, we talked, and I you mentioned you were late. It's the same vendor as we have for our patient monitoring, which we're at Philips House on the Huntington side, actually Philips on the Cedars side as well. But yes, it's an app that we have put on the iPhone 8 at that time.
So
we started that project.
Only on the iPhone, can I see it from their Loud or Central?
Yes, we actually have it on workstations as well. Yes.
Okay.
So it's the Gieras app, which is actually available through Apple, so you can download it anytime. I mean, you obviously have to make sure you have the integration. And then it's the Gieras event as part of the workstation. So our supervisors, managers, and those obviously authorized to access it can do that through their PC in their office. Yeah,
Okay.
absolutely.
And then one last quick question. So does it integrate with EMR? So an EMR like would it be like CPSI, Cerner, does it integrate with that, or is it still a separate platform?
We don't have that integrated through that platform, but we do have our patient physiological monitoring vital signs that we have selected to go across to the EMR. That is done through the Philips gateway system. So it's a different implementation.
So the vitals wouldn't be incorporated with the app. The vitals you get from the physiological monitor on the wall. It only would just be alarms.
Yes, so the Gieras app that I talked about, it would be just the specific alarms, the red, yellow, and the blue that we have selected to go directly through the Gieras app to the end user communication device, which is the iPhone.
Okay.
Yep.
Okay. Perfect. Thank you. Apologize, everybody. Sorry.
Good, no, good question.
Just something to add to that though, that nursing staff usually they don't want the alerts and alarms going to the job.
Right, I remember hearing that, I did hear that part. They want to go to the nurse station, correct?
They want
to.
it's a response. They don't want it to be documented. Unless there's a, they would document concerns. From that perspective, that's their responsibility. Right, so if you go into EHR, you could just be filled with a bunch of alarms and alerts.
Right.
If it's not being managed properly, it's automatic.
Right.
It would be very busy in the EHR record, but it is documented, and you may have missed that too, but from the reporting perspective and the Care Assist or the Care event, you can look up those reports. So if you want to do a QA, QC on your alarms on 6 West on October 14th, you can actually look all that up and you can review all the alarms for a particular patient, obviously particular room, particular nurse that was assigned to that patient. So there is a lot of manipulation of that data that you can do in this app.
Perfect.
Yeah,
Thank you.
I thought there was another question. Go ahead.
Another quick question, physical level with connectors, any issues with things that the plug wasn't seated or connected?
Not that we have, they haven't brought those up yet, luckily.
No disconnect, spontaneous disconnect. You're thinking about the cable that, yeah.
So if the cable disconnects, it would generate an alarm. Yeah. So they would go into the room and see the vent is fine. So in the education, it was part of the education to check the connection. So I guess that helps.
Nurses.
Yeah. Was somebody there with another question? No.
Biomedical staff involved.
I'm sorry, say that again.
At what level is the biomedical professionals involved in this?
The Care Assist or what? Oh, the Care Assist. So it was mostly myself, Jenna, who's our analysis supervisor, and our clinical engineer who was managing that project from the clinical technology perspective. The BMAT staff was involved in terms of testing, validation, and they are still involved as we do the monthly patching on the system. They are involved in validating all the alarms. So from that perspective.